I'm Barbara Ham Lee. It's been 10 years since the Affordable Care Act was enacted, and this year more than 21 million people enrolled in healthcare.gov marketplace or state marketplaces. And those numbers do not include private insurance through employment. Close to 50% of African Americans have private coverage, with 41% getting public coverage. There are lots of options, but the question is, which one is right for you? What should you consider when choosing a health insurance plan? Up next on Another View, the ins and outs of healthcare insurance. We'll be right back after this national, regional, and local news from NPR and WHRO News.
Discussing today's topics from an African-American perspective, this is Another View.
Good afternoon, everyone, and welcome to Another View. I'm Barbara Ham Lee. PPO, HMO, EPO, POS, HDHP, HBO. No, that's just a joke. So many acronyms that describe the many types of health insurance available. Do you know what they mean? It can be confusing, but it's important to know so you can pick health insurance that's right for you. And we're going to help you during this next hour. We have experts with us ready to share some great information. Please welcome to Another View, Chelsea Jennings, president and owner of Full Circle Insurance Solutions. Chelsea says she's trilingual with expertise in group, individual, and Medicare insurance. Hi, Chelsea. How you doing?
Thank you for having me.
Thank you for joining us. We appreciate it. We welcome back to Another View Peggy Newby. She's a registered nurse and chief financial officer for Fort Norfolk Medical Associates, and she is a certified health insurance coder. Hey, Peggy.
Hello. Thank you for having me.
Thank you for coming back. We appreciate it very, very much. And of course, our very favorite cardiologist and market director of community health improvement and engagement with Bon Secours. Could you have a longer title, Dr. Keith Newby?
I could. I could, but I didn't want to mess you up too bad.
I really appreciate that.
Not a problem.
We are so honored to have you in the studio with us today. Thank you.
I appreciate it.
I know, and thank your patience because they gave you a little bit of a break so you could get over here.
Just a little
thing.
Yeah.
Okay. So let's talk about this health insurance thing because we all have to have it. Well, let's see. Do we really? Peggy, do we have to have health insurance?
I say yes. Health insurance is just like having your rent, your water bill. It is a necessity. It's something you should sit down and budget within your household income.
Mm-hmm. Uh-huh. And Chelsea, when people say, well, I'm 21 years old or I'm, young person, I'm healthy, I eat right, I do all those things. Right. Why do I need health insurance?
Well, we aren't promised tomorrow. And we never know when something catastrophic or something outside of our control could impact our health. And so I think it's of utmost importance for that to be considered within a family's budget, but as well as understanding how it works and what the right plan is for them.
Exactly, and that's the key. So let's talk about a couple of things, ladies, because first of all, when people start thinking about health insurance plans, the first thing they say is how much does it cost? Is that the first thing, Chelsea, that you should consider?
I think it's definitely an important factor. But it's more understanding how those health plans work, how the different components work, and how they're going to match what that consumer's needs are. Price should be a consideration, but the coverage is just as important.
So, Peggy, when you first start looking, then should you just kind of forget about the price for a moment and kind of look at who's providing what you need? Is that?
Absolutely. You should sit down with a piece of pen and paper, and on that you should write the list of your providers. You should write a list of your medications because those are two factors that you'll need when you're selecting a plan. Does this provider work in this network? What is the medications under this network? Are they covered? What will be the percentage I'll have to pay for these medications? Mm-hmm. So those are two of the important items that you need to consider when selecting a health plan in addition to costs.
Okay. All right. Let's get into some of the and I haven't forgotten about you, Dr. Newby. I'm
good.
coming to you too.
I'm good.
But I want to talk about some of these different options and what they mean. Okay. So I'm going to bounce between Chelsea and Peggy on that. So PPO, Chelsea, what is that?
Okay, so that's a preferred provider organization. So I like to think about PPOs and HMOs as essentially accessibility to a network of providers and facilities. HMOs have morphed over the years. PPOs have pretty much stayed the same. It's a larger access to providers and facilities. It's typically a nationwide access to them, and it's a kind of a grouping of those providers where you can also get higher discounts from those providers. So at times you may pay a lower copay is kind of versatile in both the PPO and HMO world, but the amount that goes towards your deductible or the co-insurance could look a little bit different, which really equates to the out-of-pocket cost for that member.
And is a PPO more what employers offer?
Well,
not?
historically, but the premium, so the amount that you pay for that insurance, that monthly obligation is typically higher on a PPO plan than it is on an HMO plan. So there's actually been a much larger shift to HMO plans because there's still a very large range or amount of providers that participate in HMOs, but it kind of keeps you in more of a, think about it as like state by state. All right, that's kind of how I always like to describe it to folks. An HMO, you're going to have access to really a lot of providers in the state that you reside in. PPO is going to open it up to the nation. HMOs a lot of times don't have that out of network benefit, so you kind of get limited to staying within a certain region or geographic location where that HMO is organized. The PPO is going to give you out of network coverage. So I always like to say, if an unforeseen situation comes up and maybe you need to see a specialist out in Tennessee or Kansas or California, on an HMO platform, it's not going to be as doable. Where a PPO, that provider could actually be in network, but even if it's not, they will accept out-of-network reimbursements. And so it's not as cost-heavy on that member.
Okay, Peggy, I'm going to come to you. An EPO and a POS. Do you know what those are?
Let me know if you need some help.
So the EPO is Exclusive Provider Organization. It offers a local network of providers and facilities that does not require you to have a referral.
Okay, so that allows you to go see any doctor that you want to see.
But you have to stay in network.
But you have to stay within network.
Yes.
So is that more about specialists and that like if I want to go see a Dr. Newby who's a specialist with the heart thing, with the heart thing, that I would be able to go see him if he were in my network.
If he were in your network, but also with the EPO, you don't have to necessarily select a primary care provider. So long as that provider is in the network, you can, without a referral, go to the individual physicians.
Okay. And a POS?
Point of service plan.
Okay.
This is a plan that you can choose to select you can have a PPO, a PCP, like the HMO.
Primary care physician, that would PCP.
Yes.
It stands for, yeah. Okay.
And you're able to go out of network. They have provisions for you to be able to go out of network, which is important.
Okay.
So it's like a hybrid between the HMO and the PPO. So when you have a POS, you are in network in that HMO geographic location, but it still gives you the flexibility to go out of network and the premium differential. So again, it kind of goes back to that premium drives the kind of the network, what you want out of the network. It'll be a little bit less. So it'll be a little bit more than an HMO, a little bit less than a PPO.
Dr. Newby, then how do you decide which network you want to be in, or is that a decision that you make?
Well, yeah. Typically,
Peggy's going.
yeah. Typically, you have to apply for a lot of them. All of them, really. You have to put in an application, say I want to be a part of this network. I remember when I first started practice, I had trouble getting in one particular one because they just had it locked. It wasn't anything about credentialing. It's just they had a certain number of providers they wanted to have, and they didn't want to extend outside of that. Now, over time, of course, I was able to get in. So as you can request to be part of it, but they have to accept you in that.
And is it advantageous for you? I would think it would be, but I'm going to ask the question. Is it advantageous for you to be in as many networks as possible?
I mean, I guess it depends on the individual situation, because the problem especially in private practice is you have to look at dollars and cents. A lot of people don't really understand this is still a business. So say, like an example, some insurance carrier only gives you a certain amount of reimbursement on that patient. But I tell people all the time, we have to take into account salaries, rent, all the expenses. And now with EMR systems, I paid more.
Electronic medical records.
Yes, exactly. I paid more just on maintenance of electronic medical records. So the amount of money you have to spend on IT. I mean, I love EMR, but that cost was substantial. So if you're only going to get some lower amount of money for seeing patients in a certain group of or insurance plan, depending on how many of those you have, you may not be able to make your rent, or your other expenses because you're not getting enough reimbursement back to do that.
So you don't have a choice in how much the reimbursement is or the percentage.
You can negotiate some, but it depends. I mean, because like any other business, if you have, say as an example, a big healthcare system can command more money because they have more providers, and they know if they're not in that network, then that insurance company is going to lose out on that patient base. So when you're a solo guy, or they're like, you take what we give you and like it or don't like it, because they don't look at you individually, and because everything is on numbers in that world. So that's the downside. So you apply for it and you get accepted. You can negotiate some. And Peggy was expert at getting more when we were in the Fort Norfolk building to garnish higher reimbursement rates, but it's tough when you're an individual person.
Yeah, I think a lot of patients may think you get the whole thing.
Whatever.
We wish.
I know.
If you've ever looked at an EOB, that will tell you.
And that's the thing. So
and the EOB is an explanation of benefits. Okay, so I want to get a couple more things out on the table so that people understand what we're talking about. Out-of-pocket expenses, Chelsea, what does that mean?
Well, there's a couple different components to a health insurance plan that can be defined as an out-of-pocket expense. So in a traditional health plan, you've got sometimes a deductible, right? Mm-hmm. So a deductible is typically defined as what you as the member pay before the insurance company is willing to share in the cost. Deductibles and then co-insurance or cost share, those are kind of mingled in together. So once you...
Oh, I was going to say, so if you pay when does a co-insurance happen versus a deductible?
Yeah, so after you satisfy the deductible. So deductible first, then co-insurance, and those two components will feed into something called an out-of-pocket maximum, which every consumer should know. They should know what their deductible is. The co-insurance, yes, not as important, but the out-of-pocket maximum, that is the most that you will pay for medical and drug in most markets. There's a little caveat there, but most you'll pay for that year, whether it be a calendar year or policy year. That can kind of that drives that. And go into
normally,
that later.
What's that number around? It just depends on the
it's
insurance
all over.
company.
It really depends on the plan.
Yeah,
It does depend on the plan. I've seen some at $5,000, some at $7,000. That's the average that I have seen for out of pocket for. It varies whether it's individual coverage or if it's family coverage.
But you don't have to if your total year out of pocket is $7,000, then if your deductible is $250. I'm making up a number. You just have to pay that deductible to get the insurance to start to pay. Is that correct?
Right, for the co-insurance
to kick in.
And your deductibles, co-insurance, co-pays are another feature.
Now, what's the difference between co-insurance and co-pay?
Great question. So a co-pay is essentially a flat fee that's been negotiated between the insurance company and likely the provider that the member would pay for in exchange for services. So think about a PCP or primary care, flat office visit, a specialist office visit. Think about when you go to the pharmacy and you are picking up a prescription. A lot of times they'll say, well, that is a $10 copay. So it's a pre-negotiated fee or amount. So that's the member's responsibility. And that, along with the deductibles and co-insurance, all feed into that out-of-pocket.
Okay. So that feeds into the out-of-pocket. What feeds into your deductible? Is there anything other than you're paying out that money?
It could be all kinds of things. So I would really say anything that's not a copay.
Oh.
So if you, for example, go in and
drugs,
get
if you pay for your prescriptions,
there are certain medications that would be subject to the medical deductible. Again, it's all kind of plan driven. And that's why it's so confusing, because plans look so different and the components are still the same, but it's the way that the plan is designed that can certainly confuse consumers with that.
Right.
But the oh gosh, I forgot the question.
Oh,
Here I go on my rant.
I was talking about what feeds into a deductible to bring your deductible
Yep.
down.
Okay, sorry about that. So think about lab testing. A lot of health plans nowadays, at least, they've kind of gone away from that flat copay for. Let's think of an ultrasound or an MRI. An MRI is actually a great example. That is now a lot of times subject to your deductible and then the co-insurance. So let's say, for example, you have $1,000 deductible on your health plan. And let's say your deductible runs January 1st to December 31st. And it's January 5th, okay? You haven't met any of your deductible. You go to the hospital to get that MRI done. And they say the charge based off of the discounts that your insurance plan provides, that's going to be a $1,300 fee. And that's kind of
steep.
reality, unfortunately. So your obligation is
$1,000.
You got it. Yep. So you're going to meet that $1,000, and then there's some money left over, right? Or there's a amount left over, $300. That co-insurance would then be applied to that $300. So let's say it's a 20% co-insurance. $60, I think. I should use some easier math, but so in reality, that MRI that would have cost you $1,300 cost you $1,060. Now you've satisfied your deductible, and for the remainder of the year, anything that's co-insurance or deductible and co-insurance related, you're just now paying the co-insurance. So you're paying a much lower amount.
But that's why it's very important to have someone sit down with you as you're selecting plans, because all this terminology that we're using, if you're not in the field, it's foreign and you may not understand. Some plans, if you select a plan that's a co-insurance, 20% of the co-insurance, well, that's different than going to a doctor's office and paying a $20 flat fee. So the terminology can be very confusing.
So, Chelsea, if someone wanted to use a service like yours, because you work with a variety of insurance companies and insurance plans and so forth, do they have to pay you?
No.
Okay.
I cost nothing. We are compensated by the insurance carriers. So if a consumer, reached out to our office or my team of advisors, we'd, set up a consultation and go over, again, check providers, medications. What do you use your health insurance for? Really, those are the three basic questions that are asked or should be asked during a consult. And that's how we kind of design and can match up to potential plan options. And then, really it's could be as simple as a basic application or an application maybe through the marketplace, or directing them to, if there are other programs that may be of interest to them. So but it's actually pretty simple and free for to use an agent.
To use an agent. Okay. Dr. Newby, do you ever change a prescription or think of a different service or procedure because of someone's insurance or lack thereof?
Absolutely. They still need to get what they need to get. It depends on what it is. If My job, as I see it, is to have them look at whatever the medical issue is. Say, as examples, chest pain. We have a criteria of procedures or methodologies we have to use to identify potential causes of chest pain. Now, I think most of us, regardless, are always going to look at what's the best interest of that patient. But at the same time, if I know they're really struggling month to month, I'm not going to put them through something. If I can get away with something that may be a little less costly for them, I'm going to do that, because I usually have that discussion with the patient and say, listen, we have routes we could take. We go this route, this route, this route, give them pros and cons of each route. And I think once we've done that, then I can make that best decision, but I'm never going to withhold what that person really truly needs. But if we have options, I have to take that into consideration as a provider and as a physician. We're supposed to do that. And I think that's how the decision ultimately is driven. So, yes, I have to take that into consideration. And especially and I've had patients say, listen, how much is this going to cost? And I tell them, I said, I don't have a clue. I don't do that. I said, but we can find out. But there are certain tests I know that are going to be a little bit more costly and a little less. And if I can figure out a way to do it.
That's really funny, because I've heard other doctors say to me, too, I have no idea what this costs. So you really don't know.
I ain't got a clue. Because that's not what we do for a living. Because there's trained professionals that deal with that kind of thing. But I have an idea, because as a previous practice owner, I had to know what was coming in and how that works. So, yes, you have to take that into consideration. So, but a lot of people think that you're making decisions based on what you get. Like, they say, doctors, we just out there making a ton of money. I'm going to tell you. I don't know where they get that from.
You're not sitting on the golf course on Wednesdays.
Let me tell you something. I don't even know how to play golf. I barely can play putt-putt golf. But that's kind of stuff. Those days are done for us. We're not poor, don't misunderstand, but we don't get that. We don't get that kind of money like they used to get way back 50 years ago and higher. Those days are done.
So what if a patient comes to you and or you make a diagnosis with the patient, and the insurance company says, nope.
Oh, get that all the time.
Now, okay, so what's the process, or what do you do to try to help convince them that yes, they should pay for this, because this is serious?
This is where the game starts, and a lot of it is a big game. And this game I hate playing, because I got more important things to do. I got patients I got to take care of. I got to go fight with this company about trying to get some needed procedure done. A lot of the times, all you really have to have is your data with you. There are. They play games, but at the same time, they're a business. They're in the business to make money. They're not in it to lose money. That's like casinos. They always laugh. People go to a casino thinking I've been going here and make it. Do you realize it's people like you that gets them richer, because you'll give away all your money. So, a lot of that stuff is just a matter of understanding, your data. Why do you want to do this test, and what's the data that drives you to do that? We have to, in the cardiology world, we live by a code of ethics and procedures that was done over the years. All the literature that's out there. We have the American College of Cardiology, which is our governing body. They sit down every couple of years and come up with these new guidelines on how to treat conditions. Mm-hmm. And we follow those guidelines. If it says chest pain, this is based on, risk factors and what have you. This is how you should work that up. And we follow that. Then if you follow that, you typically will always be able to deal with it.
But who are you talking to? You talking to a clerk that's sitting there because the code doesn't match or whatever it is, or are you talking to another doctor to say, look, this is why?
This is how the game is played. First thing is you have to contact the insurance company to say, okay, we want to do this test. So typically your staff would do that. The issue becomes, and you can train your staff, but they're not doctors. So what typically happens is, they'll say, okay, Dr. Newby wants to do this procedure. Okay, denied. Okay, then they come to me and they say, well, Dr. Newby, they didn't approve it. Mm-hmm. So then they say, okay, if you want to do it, you have to do a peer-to-peer review. which means I have to get on the phone with their docs that work for that company, and I have to battle with them to say why we want to do this. And, I have won 99.9% of the time because I have my data with me when I'm going to them. And sometimes the staff doesn't always know, those nuances, and they wouldn't know. And I can't call every insurance company because I don't have that kind of time. None of us do because we're seeing patients at the time. So that's kind of the game. Now, the biggest issue for me is the medicines. Medicines are the bane of our existence, trying to get certain drugs approved.
Hang on one second, and we'll talk about that. If you're just joining us, we're talking about the ins and outs of health insurance with Chelsea Jennings, president and owner of Full Circle Insurance Solutions, Peggy Newby, registered nurse and CFO of Fort Norfolk Medical Associates, and my co-host, cardiologist and market director of Community Health Improvement and Engagement with Bon Secours, Dr. Keith Newby. So, medicines.
Yeah. So those medicines, when you have, like an example, heart failure, give you a prime example. That has been the bane of my existence, getting heart failure medications approved. If you look at the current data, and I give you a prime example, heart failure, there's 4 main medicines that they want us to have patients over heart failure. A drug called Entresto, Farxiga or Jardiance is one of those 2. Drugs like metoprolol or bisoprolol or carvedilol, those are a class of beta blockers, and then spironolactone, which is a mineralocorticoid drug. So that's what they want you on, these 4. Now, 5 years ago, before Entresto, we used to use drugs like lisinopril, losartan, which is an ACE inhibitor and an ACE receptor blocker. And all Entresto is a combination of an ACE receptor blocker and a drug called sacubitril. But that sacubitril is really what sparked the drug to work well in heart failure, but Entresto is still a brand name drug. So you got to deal with somebody saying if the ACE inhibitors and ACE receptor blockers, which are almost all generic now, so a fraction of the cost. So then you had to fight with them because, of course, the insurance company said we rather have them on those cheap drugs, even though the current literature says, this Entresto is a drug you're supposed to be on. So what happens is they'll say, okay, yeah, we'll approve it, but the patient's going to have to pay a lot more for that drug. So then then that's the next game you have to play is when you have a patient that, and I'm going to tell you, some of these medicines, I've seen them do wonders for patients. And you hate to deal with this battle. And like I said, you understand the whys, but that's when you got to deal with drug companies. Because drug companies are charging probably more than they should, I guess. I mean, I'm not in their books, but when you look at the cost of a medication, so I look at it as a multi-layered problem. The cost of the medicines, the insurance companies getting them to pay for it, but because if they drop the cost of Entresto, of course, they would say fine.
They say fine, right?
So so you have to deal with that battle, and then and that's just pills. Don't start talking about injectables. Wow. Because you even look at inhalers. I mean, inhalers can be a beast in terms of cost, and inhalers have been around for a long time. Unless you're getting something like just bland albuterol, which is the old standard, inhaler. But you look at any of these new ones, that's ridiculous in terms of the cost patients got to pay, even though they work great. But if the patient's on a fixed income, and that's why it's so important to make sure you understand what plan you have. Because the first thing people always tell me, and I've had this conversation with patients before, they're taught with a broker, but the broker says, what are your goals? What is it that you're doing, they're trying to do? And the patient will say, I want to pay the least amount I can. So, so then it's okay. Well, here's the plan.
Right. Yeah.
I saw Chelsea shaking her head over there because
not the right question to ask.
Exactly. But that's what a lot of them do. What are your goals? Listen, you asked me my goal. I want to pay the least amount I can pay. But the problem is, what is that plan going to cover? And I tell people all the time, if you know your health is jacked up, for lack of a better term, I mean, I hate to say it like that, but we're going to be real. Let's keep it real. If your health is bad, you can't get a cheap plan because the amount of money you're going to pay out of pocket. Yeah. And if you're already on a fixed income and you have 20 medical problems and you're on 16 drugs,
you can't go with the cheap plan.
You can't go with the cheap. You can, but you're going to pay so much more in the end, then if you just say, okay, let's get realistic.
So, Chelsea, what is the right question? I mean, what should you be probing for or what should the consumer expect you to ask?
Well, it's advocating for that consumer. I mean, it truly is. So if, I take great responsibility. I'll speak for myself personally, great responsibility with my clients and the consumers that I work with, because at the end of the day, we want them to get the plan that they need to take care of themselves, right? Like it's not in car insurance, right? This is insurance that could keep you alive. Yeah. And so I really start out with what medications are you on and what medical needs do you have? It's really very basic questions. Price is a huge consideration, don't get me wrong, but if you can't care for yourself, right, if you kind of downgrade that plan, just like Dr. Newby said, you're going to feel it in the end. You're going to feel it. So I mean, truly, to be a good advisor and consultant for those consumers, you've got to understand them and understand their lifestyle. You've got to understand medications, doctor needs, facility needs, and different things like that.
We got a question from Facebook. Lamont from Franklin wanted to know, does the marketplace provide an agent for you?
Oh, that is a great question. So they can. So there is a way to, I think it's called the agent lookup. Forgive me, I don't know the exact term for it. But if you, in 2024, Virginia actually created their own marketplace. So it's Virginia Insurance Marketplace. If you Google it, you've got to go down the fourth or fifth. Don't do the top. All right. But if you want to search online, you can do that. And there is a place where it says to connect with an agent. So there's a click of a button and the marketplace will connect them with certified agents. And more so to kind of take into account your geographic location as well. Okay. So there is accessibility there.
Peggy, what's the biggest issues that you've dealt with patients and the insurance?
That's an excellent question. And I will say patients truly think that the physicians know their plan, and they think that the office has all the information. And I try to let patients know that there are several plans under one umbrella of X insurance plan. There may be some subsets of plans. So it's important for the consumer to have the customer service number of whatever insurance company they have selected on speed dial, because you're paying that premium. That is your new best friend, because that is, you are paying a premium so that you have to get the most out of your plan. And oftentimes, other than health care, there are other things, there are other benefits that may be of interest to the patient. They may pay for silver sneakers plans or other things that are available, but you will not know if you don't really understand your plan. So you need to go into the physician's office armed with your updated information. Don't assume that the computer is correct, because oftentimes it's not. Make sure that the physician has your legal name as it is written on your insurance card, because that's what they have to go by. So have that information. That's most important. Also, make sure that the office and the physician knows my plan has been updated. This is what I now have. You must have that information, and you often should travel with a list of your medications, if not bring the actual bottles to the physician's office. It is very important to do that. Oftentimes, their medications sound alike. When you're on the phone and you say, I want to renew my X medication, it may sound like Y. And so the wrong thing may be in the system. So it's important to physically bring your medications to your doctor's visits, have a list of the pharmacies that you want to utilize. This will expedite your care. And have a list of the practitioners that you go to. That seems simple, but that will oftentimes save a life.
Wow. So you just need to get that stuff done. So let me ask you guys this. Let's talk about Medicare for a minute, because, a couple of years ago, I became eligible for Medicare. I was astonished at how confusing it was. And I'm thinking to myself, now I'm a fairly intelligent person, I'm on the younger end of the Medicare, group here. But for somebody who truly doesn't understand this stuff, how do they navigate that, Chelsea?
Well,
it's like
I always say, do not Medicare alone. Don't do it. Do not. Wow. Yeah, don't do it. Yeah.
So there's a couple of things. So first of all, I think for people who have never had Medicare, at least it was a shock to me and some of my friends that I spoke with. We didn't realize that you had to pay for Medicare.
Yeah.
But you do.
You do.
And if you start Medicare before you start your Social Security, you have to pay out of pocket for that Medicare.
You say, what is this bill?
Yes, yeah, and it's not inexpensive. But let's talk about the difference between a supplemental plan. So if you decide to get original Medicare with a supplemental, or a Medicare Advantage.
Great. Is that for me?
Yeah.
Okay.
Yeah.
Great
We can
question.
start with you.
All right. I always like to think about this is with a Medicare Advantage plan. All right. You can pay it's pay little to nothing up front to pay on the back end. And when I say that, maybe there's many Medicare Advantage plans, $0 premiums, right?
And with $0 premiums, right?
Which you then have out-of-pocket maximums, copay, those things that lead you to paying into that plan. Okay. Medicare Supplement, you pay up front to pay little to nothing on the back end. Okay. So premium, so that Medicare Supplement or a Medigap plan is what it's frequently called. They mean the same thing. Okay. So call it $120 premium a month. But when you go to the doctor, depending on the plan that you have, and most of them are pretty robust, you're going to maybe pay a small, and I mean nominal deductible in comparison to what normal deductibles are on other health plans. And then it's covered because it's really filling in the gaps where Part
Between what
A,
Medicare will pay for and what...
You got it, where Part A and Part B do not pay, right? So, because there's still cost share with Part A and Part B. Thing about a Medicare Advantage plan, you have to stay enrolled in A and B, but it essentially takes the place of your A and B. So when you go to the doctor and the doctor's office asks for your insurance card, if you're on a Medicare Advantage plan, you hand them just one insurance card. When you're on a supplement, you hand them your Medicare card. They might ask for your supplement card, but they actually bill Medicare directly, and then Medicare bills the supplement.
So, okay, let's go back to Medicare A and B. What's the difference, Peggy?
Medicare A is basically your plan that covers you when you're in the hospital.
Okay.
Medicare B is your outpatient coverage. Those are your doctor's visits.
Doctor's visit, okay.
Yes.
And C is the Medicare Advantage?
Right, so it kind of wraps it into the A and the B.
And then D is drugs.
The drug plan, yes.
So I got a question to throw
Go
out
ahead.
there because my bane of my existence as a physician is the dreaded donut hole.
Oh, yes.
Can we talk about that? People understand what that is because I get caught like I'm in the donut hole and I can't afford this medicine and I get that. So the question is, what's the purpose of a
What is
donut
That's
hole?
a great
hole? I
question.
don't
Who
even-
came up with
that-
this is what I'm always like. I'm like, why are you going to make my job so hard?
Like, what's the purpose of
and
it?
I speak this. I eat, sleep, and breathe health insurance, right? But for the normal consumer, it's even harder. So the donut hole, and they've redefined it or retermed it as the coverage gap. But the donut hole is, and it does not, it's specific to your drugs. So, and this is specific to Medicare and specific to drugs. And it does not matter if you are on a Medicare Advantage or a standalone drug plan that you'd have to get with a supplement. Okay?
Okay.
So there are 4 phases to a drug plan. All right? When you hit the donut hole, that means that you have possibly gone through a deductible phase for your drugs, if you have one. The copay phase, I want you to think about a copay phase. So again, going to the pharmacy, paying $10, $20 for a drug, okay? Medicare, it's so weird. They think about, there's a tally that's going on behind the scenes. They are going to they're going to add up the retail cost of any drugs that you have taken over the course of a calendar year. So they start right now, it's $5,030. It's like an imaginary number. It's not what the member has paid. It's what the retail cost is. Okay. So they're subtracting that every time a member goes and fills a prescription. Once they reach 0, that's when they transition to the donut hole. And instead of paying a copay, now they're paying 25% of the cost of that drug. So generic medications, right? Nominal, you don't experience that. Ozempics, some of those, Intruis, is that what it's called? The heart,
Entresto.
Entresto. I could name Eliquis.
All those tie-ins.
Those are $600,000 a month drugs, right? That's going to lower that 5,030 or reduce that pretty darn quickly. So it's normally mid-year or closer to the end of the year where those patients, you experience that and hear that.
For listeners who are just joining us, we are talking about the ins and outs of healthcare insurance with Chelsea Jennings, president and owner of Full Circle Insurance Solutions, Peggy Newby, registered nurse and CFO of Fort Norfolk Medical Associates, and my co-host, cardiologist and market director of Community Health and Improvement and Engagement with Bon Secours, Dr. Keith Newby. Keith, go ahead. You were asking more about the donut holes.
Well, this is the moral of this story, and this is for everybody listening, is, and I tell people all the time, live your life the way you need to live it. If you're going out eating at fast food joints and all this stuff, and you're getting yourself in trouble with your health care, then you're going to pay more for medications. Changing your lifestyle around reduces your need for medications, which reduces your risk of going into a donut hole and having to pay a bunch of money out. Mm-hmm. And that's what I try to tell people. I mean, it's not a guarantee, but I guarantee you, if you live your life the best way you can, you will reduce your relative burden of having to run into that problem, because that is the bane of my existence, because I don't know what to tell the patient. I mean, because I can't shave the cost of the drug. I mean, I'm not in that mix. I can only, and depend on the situation, especially like you talk about, people say, do you have samples of this medication? Once the drug goes generic, the samples are gone. I mean, they don't do that anymore, and a lot of companies and medical practices don't even offer the ability to have those anymore. Mm-hmm. So then you have to look at these patient assistance programs, and that's more paperwork, more forms that people are looking for me to fill out. That I'm like, listen. I mean, I'm working. I work for a living. So then you have to run to that problem. So it really can be that's why I tell people, be careful with that insurance plan that you're picking. Don't just go for the cheapest plan. Go for what you need. I tell people all the time, Peggy made a comment earlier saying, write down certain things and what are your medical conditions. Because, I mean, if you start really looking at if you're a diabetic, I mean, you can guarantee you right now you're going to be paying out some money as a diabetic, typically speaking, and depending on if you're a bad diabetic, it's even worse. If you have chronic kidney disease, I mean, which comes from that. Hypertension. If you have all these chronic conditions, your burden is going to be higher. So if you understand that and look at how many medications you're currently on, if you have if you know you have risk, then you have to plan accordingly. So your plan, how you decide what I need to do, is going to be based on where your medical condition is. So understanding that, and I tell families all the time, make sure you guys talk about your family history. Because if there's a strong family history of breast cancer or colon cancer, and you're 30 years old, I mean, you can't take that, I live right, I exercise every day. That's you can't outrun your genetics.
Yeah, exactly, because that's what it is.
Can I add one thing to that?
Absolutely.
So some of these higher cost medications, right, essentially more brand name drugs, there is a cost implication a lot of times when someone, let's say they are on an employer sponsored plan and they're looking to retire and transition to Medicare. I always say Medicare doesn't play that nice in the sandbox when it comes to medications. And, a program that you may have been able to take advantage of under an employer-sponsored plan or even an individual plan, that medication is going to the cost of that is going to look drastically different with Medicare, because they do not participate in those manufacturer discount programs. And it is a very harsh reality. Yep. When consumers are transitioning to Medicare, it's a very big thing that
and I never understand why that is. Why they don't, because a lot of times when drugs are out, like the Entrestos or the Farxigas or the Jardiances of the world, they'll give us these copay cards to give the patients. But your Medicare you can't use them.
Why?
And I
right, and
understand.
It's like, well,
that'd be the group that you would need it the most in.
You'd think, because They could be on a fixed income.
Yeah,
you know, they're
exactly.
living a different lifestyle than they were when they were working. So
I don't understand why that's the case.
It might have something to do with Medicare reimbursement and the program as a whole. Now, 2025, again, I don't know what it's going to look like, but there is going to be some what I'm hearing is some pretty significant changes with the Medicare drug programs and that donut hole and all that
That kind
stuff.
of stuff.
So be on the lookout for that.
So a question about the Medicare Advantage plans. Are you limited in terms of where you can go for help?
Okay, so back to that network type of or the network component of a health plan. Yes. So in most cases, it's going to be an HMO, a POS, or a PPO. And it's all geographic location driven. So if you've ever gone to Medicare.gov and you're like, oh, I want to look for plans, and what's the first thing it asks you to put in? Your zip code.
Yeah.
Right. So then it's going to pull the plans that are available. So yes, you are going to you're going to have a network of doctors and facilities that you have to choose from.
But if you do the supplemental, you have a greater. You can go anywhere.
Yes, because I'm not on some wood, but I haven't run into a situation where I have a consumer client that I've helped that purchased that Medicare supplement or Medigap because where they haven't been accepted because they're billing Medicare primary at that point. They're not billing an insurance carrier, but that like a Medicare Advantage plan is, right?
Oh, okay.
So in most cases, because Dr. Newby, I'll punt to you on this. So I'm pretty confident in this that you've got to accept Medicare, right? I don't know. Do you have a choice?
I don't think you have to.
No, you don't have to.
You don't have to accept primary Medicare.
You don't have
Yeah,
to.
you don't
Okay.
have to. Yeah, because a lot of people I know they were run into problems getting providers because they went to Medicare and providers weren't accepting them.
Okay.
But I mean, I personally had a different viewpoint. I felt like I was put on this earth to serve, and part of that is to, to accept what comes through the door,
Right.
and that's that's in my opinion. But I understand the whys because again, it's all about that reimbursement.
Right.
That reimbursement is not covering that doctor's expenses.
Right.
Because a lot of people think it's going in our pockets, but it's really going into rent and
oh, yes.
other
So it does-
fees. And employee costs are the biggest cost we have. And to be honest with you, it's almost as high, if not more, than doctors' costs because you need that staff to
Right.
take those phone calls and to help you fill out forms and all the other things you do. So that's where you'd asked earlier about that cost issue. It does impact.
So we have a question from Lynn in Chesapeake. She says, if someone is transitioning from Medicaid, which is a state-run insurance, into the workforce, possibly starting part-time, what do you recommend for them in terms of health insurance? Again, they need to look at the individual.
Can I take that?
Yeah,
Okay,
sure,
so-
absolutely.
Okay,
Absolutely.
so well, congratulations. Hopefully, that's a new opportunity for Lynn. But a lot of times when you're transitioning from Medicaid, and if you're offered employer-sponsored coverage, right, at that point you can kind of terminate that Medicaid coverage and enroll in that. But she did. There was a little trigger word in there, which is part-time.
Right.
So in many cases, part-time employees are actually not eligible for employer-sponsored medical coverage and some of the other coverages that could be offered. So in that instance, she could actually transition from Medicaid over to Marketplace.
Ah, okay.
Yep, so that would be her
and
good-
actually that's a good alternative because when you think about it, some people who may be moving off of Medicaid, but their salary may not be that much higher. And then all of a sudden you've got, these insurance payments that are several $100s a month or whatever they happen to be.
Right.
That's a
And-
difficult transition for somebody who's trying to grow.
So think about Marketplace coverage. So that is the individual marketplace. That's Obamacare, the exchange. We have our own now in the state. That is going to be income driven. So your premium is going to be contingent on your family taxable or household taxable income.
Okay.
Right. So, and there's like all these little nuances. There's something called the family glitch that they corrected in 2023. But it kind of starts with, you always have to start with the question of, are you working?
Yes.
And then, are you working full time? Does your employer offer coverage?
But your employer's coverage may or may not be the best coverage for you.
But I mean, by law, it may not be, right? But by law, the Affordable Care Act has done wonderful things. But there are parameters that are limitations that consumers have, because if an employer offers an employee affordable coverage, they've got to take that coverage. They can't go to the marketplace and get a subsidy, because if they do...
What? Really?
If they do...
That's the case.
Oh, yeah. If they do, they're going to get a nice little tax bill at the end of the year, because they were actually not eligible for that.
So what's considered an affordable plan?
Okay,
Yeah.
It's size does matter in the employer arena. Okay, employer sponsored market. Okay, so you've got small markets. So you've got employers that are 2 to 50 employees, or it's full FTEs, which are considered full-time equivalents. That's a whole other thing. We won't get into that. But so if you're working for a smaller business,
okay,
if you're working for a smaller business, that could be a little different. If you're working for a larger business, if the coverage is, I think, considered 95%, or I'm sorry, it's I think 8%, as long as it's not more than 8% of that person's income or their wages, right? Their salary, then it's considered affordable.
Wow. I did not know that. I thought everybody had the opportunity to go to the marketplace.
Well, you can.
You can.
You just will pay the full premium. Then there's like, what's the point? Yeah.
All right. We've got little over a minute and a half left. Last minute advice that you'd like to give people in terms of thinking about getting their health insurance.
Do not do it alone. Do not.
How did they find you?
Our office is off of Lynn Haven Parkway. We actually have a couple different advisors and consultants that can help, and they're certified in the marketplace and employer, and some in Medicare. So our website is fullcirclehealthinsurance.com. There's a contact us. We'd love to help any and everyone.
Okay, thank you, Peggy.
I would say be informed. Be informed. Go into your physician's office with that information that we mentioned. Have your updated information, have your insurance cards, have your list, and ask. If it's an older person, I would just really recommend a family member assist, because this is a really complicated process and they do need help. And the office is there to help, but they won't have all that intricate information that's needed. So go informed.
Okay.
Yes.
Peggy Newby. And Dr. Newby, you get the last word, the last 30 seconds.
Yeah, I would just say that if you need your prescriptions refilled, know the names of it. Don't tell me I need you to refill the little yellow pill. I'm not sure what to tell you on that one. And they'll say, what's in the computer? I said, no, you don't know what's in this computer. This is my computer. You don't know what's in my computer. Bring your stuff with you. I cannot emphasize that.
Are you serious? People actually say, can you fill my little yellow pill?
I mean, what medicine you take? I take a blue pill, a yellow pill, and a green pill. I'm like, okay. So just that being informed, make sure you get the help. I would say those are the things you really want to focus on. Understand what plan you're getting and what coverage you have, and be proactive.
Absolutely. Thank you all so much for joining me today. I appreciate it. And the audience, if you tuned in a little late, you can listen to the entire show at anotherviewradio.org. Thank you for spending the past hour of your life with us. We hope we had shed some light on the intricacies of health insurance. In case you missed something, you can always listen to the podcast at anotherviewradio.org, at Spotify, or anywhere you get your podcasts. Next week on Another View, Dr. Eric Claville with his award-winning Claville Report. Our theme music is an original composition created especially for Another View by Jay Sennett. Lisa Godley is our show producer. Special thanks and welcome home to audio engineer Victor Bowen, who is filling in for Jordan Christie. Dr. Barry Graham answered our phones. I'm Barbara Ham Lee. Thanks so much for listening, and let's get together again next Thursday at noon for Another View.